Assalamu alaikum guys, কেমন আছেন? I'm Dr. Asif Nawaz. Today I'm going to give you the lectures or description regarding the Bailey's and Lab's 27 editions post-operative care. Okay, so as you know that I already given you lectures about the pre-operative preparations, but there are some other care or there are some other steps of post-operative surgical practice that we usually done in the hospital, tertiary level hospital, as well as clinics and the other anywhere where the surgical facilities is available. So post-operative care is the last part of, or the second last part of the surgical practice. It is very important because when you make a patient to the surgery, so it is iatrogenic trauma that you have done to that man or woman. So after the operation, so there are some wounds, there are some inflammatory reactions and other insufficiencies that may cause the patient to some morbidity, or it could be goes to mortality rate. So there he or she needs some care or needs some steps of procedures, some medications, some psychotherapies and other terms and conditions that a surgeon must obey to make that patient fulfill. So in that case we need to maintain this care after operations, because before discharge or up to the discharge, from when the operation completed and when a patient discharged from the hospital, in between this period is called the post-operative period. Okay, before discharge or up to discharge, that level of period was the post-operative period. Okay, so in this period the care we usually give to the patient is called the post-operative care. So let's start. So now first of all, what is post-operative care? So here again the aim of post-operative care is to provide the patient which is quick, painless and safe recovery from the surgery as possible. Okay, I already given you that things. The American Society of Anesthesiologists and the Association of Anesthesiologists in Great Britain and Ireland have set standard a provision of immediate post-operative care patient. So these two institutes declare some steps or some moral values that is act as a guideline for post-operative care. So in brief, they both specify that care should be undertaken in a dedicated post-anesthetic care unit, that is post-anesthetic care unit with staff trained in the management of a patient in immediate post-operative care period. So post-operative care is delivered or given in the anesthesia ward or post-operative ward. The information provided should include the patient's name, age. So first you must make the registration of the patient, that about the name, age and surgical procedure, what kind of surgery he has been underwent, that will be discussed in that checklist. Okay, then problems, allergies, is there any drug allergies or not, anesthetic drug problems present or not, the blood loss was present or not, or what are the urine output and the surgical blood loss, how amount the surgical blood loss has been done or lost from that patient, that must be written on that checklist. Okay, so expected and a plan for the management of a pain and nausea and vomiting. So these are the post-operative complications and signs symptoms that a patient may suffer. So in that condition there are some post-operative staffs, nurses, doctors as well as anesthesiologists and the duty doctors. They will encounter this kind of sign symptoms and they will make some symptomatic relief, symptomatic treatment or antidotes, because we use opioids, anesthetics or opioid medicine for pain therapy. In that case, we use some, or they will use some antidotes or reversal agent, okay, they use to overcome that symptoms. Okay, let's go on. Okay, now the post-operative observation. So observation is very important. Watch and observation is the steps of medical therapy also, or the conservative management. So here you can see the patient's vital sign, that is pulse, blood pressure, pulse oximetry, and level of consciousness, pain, hydration status are monitored in the recovery room. So in the recovery room, we use to monitor the patient by watching these parameters, and the specific surgery specific observations such as Doppler flow for a tree flap, and the regular neurological evaluations. Laboratory tests such as blood gas analysis should also be performed when necessary. The patient can be discharged from PACU, that is post-operative anesthetic care unit, when they fulfill the following criteria. So there are some following criteria that is a parameter when a patient will go from the post-anesthetic ward to the general ward. So there are some parameters, like here you can see some parameters, like patient must be fully conscious, respiration and oxygenation was satisfactory, and patient is normothermic, not in pain or not in nauseous. Cardiovascular parameter was normal, oxygen, fluid and analgesics has been prescribed, and there are no concern related to the surgical procedure. So there are no surgically related sign symptoms present in that patient. When in that condition a patient goes on that condition, then we will decide, okay, now we can transfer the patient to the general ward. So here the summary from the Bayesian lab, that is all anesthetic patients should be recovered in the dedicated PACU unit. All vital signs should be monitored, documented, and local protocol, and treat the pain and nausea, vomiting. So these sign symptoms must be abolished. Now the observe for complications. So if there is any complication, so we have to manage that complication accordingly. Now you can see some systemic specific postoperative complications. So what the complication can be occurred of any patient, that could be surgical, orthopedics, neurologicals, neurosurgery, or others faculty members. So they all have some specific or different type of complications that can arise in the post-operative period. Like first, there are three common approaches for the classification of post-operative complication of surgery. That is link 1, link to time after surgery. Okay, so after the surgery, the time limits, like immediate flow more than within 6 hours of procedures. If any surgery of 6 hours, in that case, in that surgery has some definite complications may arise, or some surgeries of 6 to 72 hours, and late, that is from 6 to 72 hours, that is 3 days. Okay, so after 3 days of post-operative period or more than 3 days, so these are the, so complication can arise immediately, early or late. Okay, so generic and surgical specific. So there are some surgery specific complications that is usually not occurs in other surgeries, but that surgery is a specific. Okay, now the system related to the surgical complication only and is used to objectively producibly measure the impact of the surgical complication on the outcome of the patient. So complication can be indicated for how a patient will be recovered soon or later on. Okay, so here the first of all, the respiratory complication, which is so much common in every surgical patient, like the respiratory complication can occur immediately or a few days later onward. Obesity, smoking, chronic lung diseases, poor nutritional status, obstructive sleep apnea predispose to a high risk of respiratory complications. So obesity, smoking, chronic lung diseases, and poor nutritional status, so these are so much common in everywhere in our country. Like most of the peoples in the low socio-economic region, and they are poorly equipped, poorly nutritionalized, and there are many bad habits like smoking, betel nut chewing, and others like other bad habits also present there, so that respiratory complications is so much common. Early interventions and multidisciplinary involvement can prevent life-threatening respiratory complications. So we have to identify that complications as soon as possible, and then that should be treated accordingly as early as possible. Now the respiratory system. So these already been discussed, that is upper airway obstruction is most common. Okay, so there may be persistent relaxation of airway. Laryngospasm can be occurs after in the anesthetic period immediately after surgery. Soft tissue edema can be occurs in the wound infection or wound area. Hematoma, or if the blood vessel leakage or ligature of the slip of the ligature sometimes can causes hematoma and abscess. Then foreign body may be present, like suture material infection or foreign body that may be anything from the, especially from road traffic accident or trauma patient. These residual effects of anesthetic drugs, like some people has some metabolic problems or maybe hepatorenal impairment. So in that case, anesthetic drugs will work for a longer period of time, because their pharmacodynamical effect of drug elimination was slow. In that case, anesthetic effect of the patient can be work for prolonged period of time. That is, neuromuscular blockers, anesthetic agents, opioids can contribute reduce impaired adequacy of ventilation post-operatively. So that drug effect will causes post-operative anesthetic complications. Okay. The hypoxemia is consequence of acute pulmonary edema, that is fluid overload, cardiac failure, post-operative, post-obstructive complications like bronchospasm, pneumothorax, aspiration, rarely pulmonary embolism. So patient with hypoxemia should be treated urgently. Okay, hypoxemia is a life-threatening or alarming situation that a patient may encounter. So in that case, it must be treated urgently. If the patient is breathing spontaneously, oxygen should be administered like 15 liters per minute using a non-rebreathing mask. So this is not absolute things, but it is given in the Bailey Dunlop's book, but this can be changed according to the geographical areas and the availability. Okay, so early and late postoperative pulmonary complications are the significant cause of the postoperative morbidity and mortality. So pulmonary complications can be determined as a rate or the statistical analysis of the morbidity and mortality rate of our country. Not only this country, but also the other countries where there is a lack of manpower, lack of facilities, and lack of knowledge or the training programs. In that case, pulmonary problems must be resolved so much quickly and with adequate instrumentation and the proper manpower. Okay, so complications include fever, so microatelectasis, cough, dyspnea, bronchospasm, hypercapnia, atelectasis, pneumonia, and pleural effusions, pneumothorax, and respiratory failure. So these are the symptoms a patient may have. So in that case, you have to regard it as a respiratory complication arise in that patient. Now here the cardiovascular system is the second most important complication that may causes increased mortality and fatality rate. Okay, so that is a cardiovascular complication. So first things is the you can check these things like pulse, blood pressure, echocardiography, and that will indicate is there any cardiac complication present or not. That is hypotension, hypertension, both can be occurs. So but hypotension, it's a term because postoperative hypertension is so much common. In that case, we use dopamine or fluid management, proper fluid management to make the blood volume adequate. Hypotension may be hypovolemia, myocardial impairment, that is MI. Postoperative MI is life-threatening, and vasodilation, subarachnoid epidural anesthesia. Other causes of hypotension, surgical bleeding. Okay. Now another cause was surgical bleeding, sepsis, arrhythmias, and tension pneumothorax, pulmonary embolism, pericardial tamponade anaphylaxis should also be concerned in the different diagnosis. So these all can be occurs, not all, but individual problems can be occurred in individual patients. So you must evaluate which complication is arised, and in that case hypertension is showing in that case. So postoperative hypotension leading to end organ dysfunction. Sometimes there be multiple organ involvement can leading to hypotension is a sign. Okay, so urine output less than 0.5 ml, because we all know that in every hour 1 ml of urine must be produced. So if that is less than 0.5, that is 0.5 ml, in that case there is a renal complication or renal shutdown is anywhere in any time that patient may suffer or may fall in the renal failure or renal shutdown. So decreased level of consciousness, myocardial ischemia, capillary refill less more than 2 seconds. So there may be a dehydration, or if there may be a severe blood loss or severe plasma loss, in that case dehydration is imminent. And capillary refill time more than 2 seconds. Okay, so here you can see the cardiovascular complication, hypotension, hypertension both can be occurs. Arrhythmias, myocardial ischemia, stroke, these all can occur due to electrolyte imbalance. As you know that the most important cause of arrhythmias was hyperkalemia, that is increased potassium levels. So you have to measure how much potassium present in that case, either it is hyperkalemia or not, or hypokalemia. You have to maintain the proper potassium level, or if that is increased, so you can administer insulin or salbutamol solution, or increase excretion by giving diuretics like furosemide or Lasix, others. Here you can see the renal and urinary system problems. Here you can see some pre-renal, renal, post-renal complication like hypotension, hypovolemia, nephrotoxic drugs, gentamicin, diuretics, NSAIDs, myoglobinuria, where it is a most threatening complication after if we found this myoglobinuria. In that case renal shutdown is imminent, because it is invariably found in case of road traffic accident or limb surgery like orthopedic surgery, any fracture surgery. We can see some myoglobin, because myoglobin present in the muscles. If the muscle is damaged, in that case myoglobin will be released on the blood, and it will go through or filter through the glomerulus, and ultimately myoglobin is very toxic and it will destroy the glomerular filtration. So renal shutdown is imminent. Post-renal ureteric injury and blocked urethral catheters. So these all can be occurs in the postoperative period and may causes acute kidney injury, AKI. So urinary retention, so you must check the urobag perfectly, either it is fulfilled or not, and 24 hours urinary output must be measured. If there is any fever or there is any pain in the urination or not, so there may be chances of UTI, postoperative urinary tract infection. Okay, retention may invite infection. Okay, so post prophylactic measures to prevent renal failure should be taken at high risk, so there will be high risk cases. Okay, so inability to void patient, as you saw, this is been discussed here, and it in short from the Bailey lab summary. Now here it is the medicinal topic, that is the postoperative delirium. Sometimes patient complains about the lack of sleep or lack of confidence. Sometimes he feels that he will never gonna be okay, or never gonna be fit like as previous to surgery. So in that case we have to give some counseling, or we have to give some medication to keep the patient calm and quiet, so that the proper relaxation is established. In that case there are many causes, many diseases can arise from the simple delirium. Okay, postoperative delirium has increased a frail and elderly population, so it is occurred in the elderly population, and the postoperative delirium is increasing nowadays. Okay, There are two types of delirium, hyperactive and hypoactive. Some patient is so much excited or some patient aggressive and some other patients may be very much fatigued or very much lonely, or psychogenic problems can be arised in some kind of patient. So they are in hypoactive variety. So seizure or convulsion can be occurred in some unexpected patient, like young female patients or a very fearful patient. There's the patient who may be suffered from previous phobia or any kind of psychogenic disorders. In that case, seizure can be occurs associated with that disease. So here you can see some problems, like maybe this kind of causes may patient have, like hypothyroidism, Addison's disease, epilepsy, previous head injury, CVA, like this cerebrovascular accident like stroke or hemorrhagic stroke or ischemic stroke. So opioid or the previous drug abusers, cocaine abusers, alcohol withdrawals, because a patient might not have these kind of things in postoperative period. In that case, delirium can be arised. Arrhythmia or dehydration, septic shock, MI, chronic heart failure, pulmonary embolism, these can be also occurs, because sometimes some patient hide these kind of complications. So patient will reveals delirium, so we have to find out either which disease a person possessed from previously, or what diseases are arised from the very beginning of the postoperative period. So we have to identify every diseases accordingly. Now the postoperative bleeding is important complications. Okay, so all hospitals should have a major hemorrhage protocol in the places. So the managing hemorrhage or bleeding has the guidelines of different hospitals. They follow their own or their local hemorrhage control protocols. So they need to transfuse blood in absence of continued bleeding in the patient's hemoglobin more than 75 gram per liter should be weighed against the risk. Okay, this is the parameter, so it is not always followed, but bleeding is immediate. Postoperative period is very common. All patients must have vital signs, so you have to check these vital signs, urine output and levels, and 24 hours surgery. After surgery of 24 hours, it is very crucial. So that crucial period must be crossed, and any bleeding can be occurs within 24 hours. So if hemorrhage is suspected, blood samples should be taken for a full blood count, coagulation profile and cross match. So these are the things that is emergency procedure. So if a patient came with hypotension or paleness or the postoperative severe bleeding, so you have to make the emergency blood bleed, hemoglobin, cross matching and other things, coagulation profiles to collect the adequate blood as you need, because sometimes maybe you think 2 to 3 bag of blood you need, but no, after the report come you see there are a lot of blood is needed. In that case you need some times to collect the adequate amount of blood. So these things is very quick procedures. If the source of bleeding is doubt, then the patient is stable. An ultrasound, computed tomography can be required determining the nature of bleeding. So sometimes you may not find the cause of the bleeding or the blood vessels. In that case, emergency you have done, you have to be done the CT and ultrasound as well as some other procedures. Sometimes re-laparotomy is necessary if you have any doubt that there is a faulty, there is a chance of leakage, or there is a chance of dislodgement of any ligature. In that case, re-laparotomy is considered or allowed. So there are some general complications also, like the deep vein thrombosis, that is DVT, is a well known and complicated by pulmonary embolus and potentially fatal complication surgery. So this is very emergency, so you don't have any thinking about the DVT, because the patient may sit in front of you and he is talking with you, but suddenly the patient called you, I have suffering from breathlessness, and patient is unconscious and death due to cardiac arrest. So you don't have any time to evaluate, you don't have you will not going to have time for make a decision either what you will do in that case. So DVT is very sudden condition. So cough pain, sometimes some patient will complain cough pain, swelling, warmth, redness and engorged vein. However, most will know physical sign. So you see there is no physical sign. On palpation the muscles may be tender, there may be positive Homan sign, that is cough pain. Homan sign is important signs of vascular surgery. Sometimes Homan's operations is done. So Homan is an important man who describes the cough pain, dorsiflexion of the foot. These are these symptoms. If a patient complains, so we see Homan sign in DVT patient. We usually press the cuff and the patient is feel pain, and the dorsiflexion of the foot is voluntarily we perform dorsiflexion of the foot. In that case, patient will present pain. Okay, so duplex ultrasound and the venography can be used to assess flow and the presence of thrombosis, and other investigations include D-dimer. D-dimer is very popular nowadays because now is a pandemic. So if there is any intravascular coagulation, so DIC either present or not, so we use D-dimer or to see the vascular status. So here is some risk factors that like maxillofacial surgery, neurosurgery, cardiothoracic surgery, so medium inguinal hernia, abdominal surgeries, gynecological surgeries, urological surgery, and the pelvic elective trauma surgery, total knee hip replacement. So you can see the major surgery has increased risk of DVT, that is pelvic surgery. So either these are the so minute operations. Nowadays laparoscopic surgery is so much common, and as it is a minimal invasive, in that case there is a less chance of DVT. So either if you make more handling, more cut or more massive surgery, it will increase the chance of more chances of DVT. Okay. Now the general postoperative complications, also the pulmonary embolism. Okay, it is a life-threatening complications. Pulmonary embolism is not usually an immediate complication, but can present in postoperative period. Thrombus can arise in DVT of the leg and vein and vena cava or the right atrium. And the sign symptoms depend on the size, and embolus may range from dyspnea, cough and periodic chest pain to sudden cardiovascular collapse. Okay, I already told you that story of pulmonary embolism. So after initial resuscitation, the patient will need anticoagulation, initially parenteral anticoagulation followed by long-term oral anticoagulation. Now the fever is so much common because if there is any cut, if there is an inflammation, so as a symptoms of inflammation, fever is common, a very common problem. Consider infection of the lung, urinary road. So if the fever comes out, so first concern that is there any lung infection, patient has any cough or any change of voice or any cough, sign of cough present or not. Urine, is there any adequate urination occurs or not, or is there any pain or any problems occurs in the bladder or not, and the wound. Or how about your own side? Okay, own side, is there any infections of own side or redness or swollen pain, others? So in these three areas we will found where is infection present or not. So here you can see the causes of raised temperature. Postoperative include the atelectasis of lung, that is increased lung congestion, superficial deep wound infection, chest infections, UTI, wound infection, anastomotic leakage or intracavitary collection or abscess present or not, like abdominal abscesses, subphrenic abscesses and pelvic abscess. These are the so much common nowadays after the post-operative surgery, or misplacement of drain. If there is not adequately placement of drain present or not in that area, in that case abscess, hematoma or other complication may arise anyhow. Now the possible cause of pyrexia of a non-infective origin, also DVT, transfusion reaction, wound hematomas, atelectasis and drug reaction. So these can be occurs also. Now the wound dehiscence. Okay, wound dehiscence is a complications post-operative wound dehiscence. Wound is ruptured. So what are the risk factors? Malnutrition, diabetes, obesity, renal failure, jaundice, sepsis, cancer, treatment of steroid. You all know that because it is already been discussed in the on healing and on healing chapters. So this is very much common and very important for post PG exam, part 1 exam, that is what are the risk factor of wound dehiscence: malnutrition, diabetes, obesity. These are locals: inadequate pore closure of wound, poor local wound healing, increased intra-abdominal pressures, post-operative patients suffering from chronic obstructive airway disease, and during excessive coughing. So excessive coughing will make increased intra-abdominal pressure, okay, that will hit to the wound side. Now the pressure sore, okay, pressure sore, that in the previous class I already told you that surgeons make concern about the pressure areas of the patient and perfect positioning in the operating table. Not only that, but also the post-operative bed. So some patient is very debilitating and they are not moving their bodies in a very limited time period. In that case, that pressure area will be necrotized and dead. So recognize the patient at risk. So we have to separate the risk patient, and it gives the additional nutritional status and some therapeutic benefits like airbag or other things like bed bound. So mobile, so keep the patient mobile for a sustained period of time regularly. So this is all here. I already told you that air mattress is used as a air bag also called, which automatically relieves the pressure areas and mobility. So you have to make the patient mobile. So if you make early immobilization, so there will be good healing, okay, and the less chance of pressure sores. Okay, now some specific complications of surgery. So there are other complications of surgery specific, that is the abdominal case. In case of abdominal surgery, the abdomen should be examined daily for excessive distension, tenderness and drainage from wound and drain signs. In certain operations such as those for intestinal obstruction, esophageal and gastric procedures, a nasogastric tube may be required, okay. Sometimes nasogastric tube is used, and the distension occurs or not, tenderness present or not, drainage system, how the drainage system and the own drainage system you have to check every day. Paralytic ileus. Paralytic ileus may present with nausea, vomiting, loss of appetite, bowel distensions, because paralytic ileus means there is a lack of peristalsis. So abdominal distension, nausea, vomiting, that all can be occurs anytime. So following laparotomy, gastrointestinal motility temporarily decrease. So treatment is usually supportive, maintenance of adequate hydration and electrolyte level. So hydration, electrolyte level and supportive therapy is enough for maintaining this. Localized infection and abscess may present with persistent abdominal pain, focal tenderness and spiking fever. The patient may have a prolonged ileus. If the abscess is deep seated, this symptom may be present, okay. So this is a deep seated infection. If there is any chances, in that case abscess may occur. The patient will have a neutrophilic leukocytosis, may have a positive blood cultures. An ultrasound or CT scan of the abdomen should identify the suspicious collection, will identify subphrenic abscess, okay. Here very important. So patient neutrophilic leukocytosis is an early sign. Ultrasound reveal or CT scan reveal subphrenic abscesses, and they have a high fever, unconsciousness suddenly in the day of discharge. That means a patient was good during the day of discharge. Suddenly a patient suffering from huge fever and pain and unconsciousness. In that case, the patient may have the subphrenic abscess. Now the orthopedic surgeries. So orthopedic surgeries has some specific problems like compartment syndrome, neurovascular, supply of the extremity. Okay, compartment syndrome is very dangerous complications. Okay, raised pressure on the osteophyseal compartment can prevent adequate pressure, perfusion and the present after surgery. Patient with compartment syndrome complain of pain out of proportion of that expected. Pain is that increasing pain, passive stretching of the muscle in the affected compartment. where you can see some key features like pain out of proportion, pain that is increasing progressively, pain on passive stretching of the muscle is in the affected compartment, paralysis, paresthesia, pallor, pulses generally occurs lately. That is very bad, because if that occurs, then amputation is the only sign to survive the other organs. Fasciotomy is usually done to relieve the pressure within the osteophyseal compartment. So fasciotomy is usually done. Further management required. Experienced judgments may include compartment pressure monitoring or the fasciotomies. Okay. Other modalities of surgical branches like neck surgery has a thyroid surgery. Must observe the accumulation of blood in the wound. So bleeding is very much important for thyroid surgeries. In the case of thoracic surgery, 24 to 48 hours is very crucial, because chest drain require regular review. If the fluid in the chest drain swing, then the drain is correctly inserted in the fluid cavity. So swinging of the water seal drainage fluid, that means the tube is functioning. Now in case of neurosurgery, postoperative pain, patient should keep under close observation. So we have to make the close observation. A rise in the intracranial pressure may be signaled by a deterioration of the state of consciousness as well as neurological signs. So state of consciousness is important in case of postoperative neurosurgery patient. Okay. Vascular surgery, the patency of the graft. There are many graft operations was done, anastomosis and graft. So patency of the graft is the question of things. So femoropopliteal bypass. So there are different bypass surgery. So how was the graft in that area? So how was the distal part where the graft done, and how the vascularity? So it is being checked regularly. Okay. Yes, in that case Doppler ultrasound is done to check the patency of the graft. In the plastic surgery, viability of the flap is crucial. That is, the flap we used or transplanted or the grafted, how was is it viable or not? So viability test is usually done and monitored regularly. The blood supply may be compromised by the position, dressing, collection of the fluid and blood beneath the flap. So these things must be checked. The how was the patient lying on the bed or in his own position or not? Dressing, how was the dressing? Is it pressure dressing or not, or is it slide dressing? And the collection of fluid, is there any collection of fluid or any drain placement, or how was the placement of drain or proper position of the drain? That must be concerned. Now postoperative vomiting and nausea, as you know that this is very common, because sometimes nausea and vomiting can be occurs due to the drug problems. Postoperative medication, there are some medications may provoke nausea and vomiting, like you can see like some other things like antibiotics, like some anti-analgesics, some NSAIDs may causes nausea and vomiting. In that case we will manage with the H3 receptor agonists like dexamethasone, steroid, phenothiazine, and antihistamines is the most effective sometimes to reduce the signs symptoms of vomiting. Okay. So enhance recovery. So what can we what measures we should take to increase the enhanced recovery, to ensure the enhanced recovery? So early planned physiotherapy and mobilization. So we have to make the patient mobile as soon as possible. Oral hydration and nourishment must be done. Okay. And the opioid sparing analgesia regimen, that include the use of regional block and regular non-steroidal. So we have to avoid the opioids. So we have to leave the opioid and must make some alternative with NSAIDs and other pain relieving drug. Okay, because opioid makes withdrawal syndrome. Opioid makes the patient more fatigued, more bedridden. So opioid must be spared. Discharge of planning is started before the patient is admitted to hospital. That involves support and from the stoma care nurses, physiotherapists and other community care workers. So first of all, before surgery we must have some counseling to patient that when you will be discharged from the hospital. So that time must be told to the patient, because it will give some psychological support to the patient, and the stoma nurse and other physiotherapists and other community must be aware of that patient will go in that day. So so all the members of healthcare providers will nourish that patient, will make their work perfect, so that the patient can go in that day. So it will give a patient additional support from his mind. In that case, enhanced recovery will be established. Now discharge and follow up. So this is the last slide. So now the patient is ready for discharge. So there are some notes that we will give to the patient, so that the patient maintain the treatment to his home. That is diagnosis, what was the disease and what was the treatment plan, what are the laboratory results that with the test we have been done, and what were the complications that is managed in the hospital, and what can be done, what can be arised in the home. So that counseling must be done, and the support needed. So patient must need some manpower, or the patient may need some medications, and the other additional support a patient may need. So in that, like stoma nurse, like physiotherapists, so maybe they can go to the patient's home and provide the supporting treatments. And the follow up. Now the patient should be reviewed in the clinic when a key decision is management need to be made. Sometimes we will give suggestion the patient to come to the hospital if there is any complication arise, or if you don't understand the problems, in that case you will come to the hospital. And after a few postoperative period, like 6 weeks or 12 weeks, after 12 weeks or 6 weeks, we advise the patient to come for a follow up. Okay, so the patient at the clinic appointment should be included in the letter of patient GP. So that is all about the postoperative care. I know this is a very big topic, but there are many training options. So I hope you will understand the checklist, understand the complications that can be arised in the postoperative period. I hope this is a global pandemic, so I hope you will stay in your home, take care of yourself, about your family. So stay home, stay safe. Thanks for patient sharing. And how was my video? Please like, comment and subscribe my channels, and as well as give me inspiration, so that I can make more videos like these. And still I'm working on it, so there will be more surprises that you will see in your near futures, because I'm going to make different videos of from the surgical practices, like trauma, like GIT, urinary. So that there will be many videos that will come in the future. So thank you very much for patience watching, and thank you very much for supporting me, and peace.